Hello everyone, my name is Dr. Sleiman Obeid from the University Hospital of Zurich, where I work at the Andreas Catheterization Lab, and I'm going to give you a little bit of a description of percutaneous coronary intervention, the procedure that we do when patients come with a suspicion of occluded coronary artery. So first I'm going to give you a little bit of a brief history where this percutaneous coronary intervention started and when. It all began with Dr. Fossman, a radiologist, who did the first right heart catheterization on himself in 1929. The second major time point was with Dr. Andreas Krunzig here in Zurich, and that was in 1977, where he did the first balloon angioplasty in a 38-year-old conscious patient. And lucky enough, this patient, after quite some years, maybe 40 or so, he's alive and doing fantastically great. The second major point that I would like to describe would be the stent implantation, which was done in 1956, around 1956, let's say, and that was by 1986 actually. That was by Dr. Siegwart and his colleagues. The first was in Lausanne and Toulouse almost together. In order to understand percutaneous coronary intervention, I have to give you a small description of what is coronary angiography. And coronary angiography is the process where you inject some dye, which is iodine-based, into the coronary arteries. You see them black, they're blackened out by the dye, and you could actually see if there is a stenosis or occlusion in these coronary arteries. And actually there are three major coronary arteries, one from the right side, one which is the left anterior descending, it comes from the left side, and the other one coming from the left side also is called the circumflex artery. So there are three major ones. How do we do this? We first have to find access into the arterial blood system, which is majorly either from the groin through the femoral artery or from the radial artery. We have to do a small puncture for anesthesia, then we puncture the artery, we insert this special sheath which gives us a permanent access into the coronary, into the arterial system, and then followed by what we call a guide wire, which goes through the radial artery or through the femoral artery up into the ascending aorta, after which we have this hollow special catheter where we could inject the dye through and see the coronary arteries. What is balloon angioplasty? Follow the same procedure. Do the same local anesthesia, you do the same puncture, you put the sheath, you put the wire up to the aorta and the sinuses down here, and then you use a larger catheter which is also hollow, and you could put any type of material you require through this catheter. So now we have the catheter inside the coronary arteries. We do a small injection, we say this artery is occluded. We now require this small coronary guide wire, which is quite thin, 0.014 inch. We go through the coronary arteries, we wiggle a little bit, we pass through the stenosis, we go down deep into the coronary arteries. We still require the balloon, which is not unlike that used by Dr. Grunzig in 1977. We follow up over the wire, we go into the coronary arteries, we place the balloon in the stenosis, and what we have to do now is pump it up, blow the stenosis. How do we do that? We have this small indeflator which injects contrast and a little bit of water inside the balloon, so the balloon is filled up, and then there's a pressure coming, pop, the stenosis is open. And that was the simple percutaneous procedure of balloon angioplasty. At that time, they just popped the stenosis with the balloon, removed everything out, and then checked if the artery is open or not. It was fantastic, this discovery and this application in human beings. It saved a lot from undergoing coronary artery bypass surgery. but it still had its disadvantages. As you could see from this slide, around 40% of the patients who just had balloon angioplasty came back because the coronary artery got stenosed again, or what we call had a small recoil. So we opened up and then it recoiled, it closed. We had to do and investigate for further better material, and the idea of stents, some metallic stent to open the artery and to maintain the artery open for a longer period. And there was actually a bare metal stent which was initially placed in these arteries, and by itself it decreased the restenosis rate from 40 down to almost 20%. So there is 50% reduction in this restenosis. We have this new material, this stent. It could just improve the outcomes in such patients. And so we thought, why won't we make it better? So the first stent was bare metal stent made up of stainless steel. Let's improve this metal. So we put cobalt chromium, and we used cobalt chromium instead. Then let's say we want to improve it more. We added a small medication drug on the stent. Most of these drugs which are now coating the stents nowadays are initially used as anti-cancer therapy. The first of which was rapamycin. The second was sirolimus. And now we have lots of versions of this sirolimus, everolimus, sirolimus, lots of amus in the end. And they're quite good in preventing restenosis and maintaining the coronary arteries open. So why do we do it? Well, it's actually quite a very interesting procedure, and it just relieves the symptoms. Patient comes, he's in pain, severe pain. He has this pressure over his chest. You do the coronary angiography. You see the occluded artery. You put the wire, you put the balloon, you put the stent. Everything opens. Symptoms are relieved. Patient is feeling much better. So symptom relief is very important after this procedure. The other major thing is in patients with acute coronary syndrome and ST elevation myocardial infarction. They live longer when you do this procedure fast enough. You salvage their myocardium, they have better outcomes, and they almost live as normal people without, compared to those who do not have coronary artery. So they do quite fantastically good. Patient is okay. You opened his coronary artery. He's doing fine. You pass by him the next morning. Say, how are you doing? He says, oh, I'm doing great, but I still have this question of is there something that I should be taking for this stent, or what medications should I be taking? And you say, of course, there are some medication which you should be taking in order to maintain the stent open, because you explained that the stent is foreign material and the body just does not recognize it, does not like these materials. So everything just attacks it, from the platelets to the white blood cells to all the inflammatory material. They want to close it. They want to just eat the stent, and you don't want that to happen. You want it to stay open. So you say, I'm going to give you aspirin, the most common prescribed medications in such patients. And second would be just another medication just to be more powerful, more tough. And they all act on this platelet function. So they prevent the platelets from functioning and hence thrombosing this artery. For example, clopidogrel, prasugrel, ticagrelor are other examples of medications which these patients could have. Finally, what should you expect? What should the patient expect? Well, let's say patient came presenting with an ST elevation myocardial infarction, and you put a stent and patient is doing fine, and he says, how am I doing, doctor? What's going to happen to me? And you say, you're doing fine, but I have to say that in such cases, there are some events which could happen. And at 1 year, around 9 to 10% of patients with such a big infarction might have or might die. On the other hand, there is also probability that you might be coming back for another stent, or that you might have another myocardial infarction in the following year. And this goes up to around 15%. And this is all related to this ST elevation myocardial infarction that you had before. However, there are some group of patients which also present with chest pain and are identified as acute coronary syndrome. They're called non-ST elevation myocardial infarction. And to some extent, they do a little bit better. So this major adverse cardiac event, this summation of a reinfarction or requirement for further stentings or for further balloon angioplasties, is around 10%. So it's a little bit less than the 15% in the patients with ST elevation myocardial infarction. However, overall, with new materials, there's always potential for improvement, and we are now having third and fourth generation drug-eluting stents. So I hope you enjoyed this lecture, and you could also check the ESC guidelines, which we use actually here, the European Society of Cardiology guidelines, online for further information. Thank you for listening.